I'm saying is, when you're explaining what you're doing, just keep it simple. The talking part should be less than 2 minutes. Less than 2 minutes. Because then you only have, how much you get? 15 minutes to do all that?
Yeah.
Okay. Now you can do a lot of different, you can do everything a lot of different ways. It sounds like Beth has been telling people to go right in, see the patient in their natural resting position. First thing right off the bat, hey, I noticed that you're sitting in a kind of a slumped position. Maybe your blank would feel better if you were sitting a little bit more upright, because then the stress would be more evenly distributed in your body. Let's work on an anterior pelvic tilt, or let's work on an I don't know, or let's work on a chin tuck. Those are pretty much your 3 staples.
Mm-hmm. So posture first, pretty much.
I would say choose one. Yeah, I mean, I'm saying this is what Beth is saying. Beth was saying that's the first thing you could do, is you could do your postural education, give them something to work on for that, and then after you've taught them good posture, then it's a lot less instruction with your testing and everything else, because they already know how to hold better posture, so that you can just remind them, hey, go back to that good posture, and then let's reassess your cervical rotation, or cervical extension, or whatever it might be. So you could start by doing the posture right off the bat, and then they have better awareness of where you want them to be for all the tests and the exercises. Or you could jump in as the flow of the form shows. You could do your range of motion, you could do your MMT, and based on what you assess, you could do the range of motion and say, you have a deficit in cervical rotation, let me give you a stretch for that. Then you test MMT, I see that you have a deficit in this, let me give you an exercise for that. So you can do it a lot of different ways. You organize what makes sense to you. And then, so you can do both assessments and then give 2 exercises, or you can say, assess, I see a deficit, here's your exercise. Assess, here's a deficit, here's your exercise. Whatever's easiest for you. But try your best to make sure that the posture and the exercises overlap a bit if you can, so that you can be a little bit more efficient with your time. So, the other thing you want to be considerate of, just as a reminder, is if you can organize your testing and your exercising in a way that minimizes having the patient change positions, that would be ideal. But that's more style points at this point. It's going to be something that we're more meticulous about on the final for this course. But it's something to get in the habit of, truthfully. Okay, so, posture. Almost every one of your patients that you see, just because it's a natural human tendency, is going to be in posterior pelvic tilt. They're going to have increased or excessive thoracic kyphosis. They're going to have forward head posturing. Okay? So reasonably, as a treating therapist, it's my style of practice to say, we can do a lot of stuff from the head, neck, or shoulders, but if you don't fix the foundation, then everything else is still going to be kind of out of line. So I tend to go with, let's work on some anterior pelvic tilts first. And you can have them do it in supine, have them work on doing pelvic tilting here, because sometimes people have tightness or a semi-rigid pelvis from sitting slouched for so long. You can have them sit on a sisal disc or a pillow to try to make their pelvis a little bit more movable. And remember, this is just to kind of give them a little bit more body awareness. Because when they sit on something that's unstable, they can move their pelvis easier. And because a pelvic tilt is such a subtle movement, it's hard